Hello, everybody. My name is Elias Jabbour from MD Anderson, and today I want to give you an update on Philadelphia positive ALL. Historically, when we see somebody with ALL Philadelphia positive, the first thing to think about is transplant. And historically, only patients who received transplant did well, not amazingly well, but still have a better survival than those who did not have a transplant. Things have changed in the year 2000 with the availabilities of tyrosine kinase inhibitors. We've used imatinib, we've used dasatinib, and we combine them with chemotherapy to further improve the outcome. Unfortunately, despite these novelties, the survival has never gone above 50%, and that is if you consider transplant in all comers. So standard of care today is TKI plus chemotherapy and transplant, and in USA today, hyper-CVAD dasatinib is the most commonly regimen used. But as you can see, we're plateauing all ages together, all patients at 50%. Why is that? Well, there's two reasons for this. Number one, while patients do respond to treatment, we're not eradicating minimal disease. We still have some residual disease present that may lead to resistance and relapse. Number two is we know with these TKIs, mutations emerge that can prevent the binding of the TKI to the oncoprotein, and therefore we needed better tyrosine kinase inhibitors. It has been shown in work from France where patients who received dasatinib treatment progress, the dasatinib-based regimen and progress, they acquire in the most common situation the mutation called T359. Therefore, if we want to improve the outcome, we must suppress the emergence of this mutation. Based on this, improving on the rate of molecular responses, preventing the emergence of T359 mutation, we design a regimen with the ponatinib hyper-CVAD. Ponatinib is a very potent tyrosine kinase inhibitor. It does overcome the problem of the mutation. Therefore, when we combine it with the chemotherapy, as we did in 2010, we've shown in 86 patients that responses can be on almost everybody. When you look at the minimal disease eradication, we were successful in 84% of the cases. And we've reported the best survival so far at 6 years of 75%. Now, I mentioned that the dogma is to go to transplant in all these comers. When we wrote the study, we said whoever has the donor option should go for transplantation. 20 patients received transplant, and by performing landmark analysis, we've shown for the first time that transplant may not be needed. In fact, those who did not have a transplant had a better outcome. This study did not say do not go for transplant, but what we're saying here, maybe if we use the best treatment up front, we can avoid the need for transplantation. We used to give 8 intrathecal, and historically patients had a poor outcome, therefore did not live long enough to have CNS relapses. And we thought TKI can cross the CNS barrier, among them dasatinib. We tend to be wrong. We need to give more intrathecal chemotherapy to avoid CNS relapses, and we've shown giving 12 versus 8, 12 is better to avoid relapses. Therefore, do not rely on TKI to prevent these relapses. You must give more intrathecal, and this will become more relevant as you're going to see in modern time, we're walking away from chemotherapy and we're using immunotherapy where we need more CNS prophylaxis. Now, then the question is, do we need a transplant, yes or no? There was a propensity score matching in data from 5 institutions led by our colleagues at Washington University in St. Louis, where we took patients to achieve a CMR. We matched them transplant, no transplant. In those who did not receive transplant, we may have a higher rate of relapses, but this was negated by the mortality from transplant. Therefore, today, if somebody is achieving a complete molecular remission, transplant doesn't add anything. So it's a change in the management of ALL Philadelphia positive, where if you have a CMR, transplant is not needed. Therefore, we must do our best to induce a CMR early on to avoid subsequent transplant in the future. What is the best TKI? We have different TKIs available today. In pediatric setting, there was a randomized study comparing dasatinib to imatinib in Philadelphia positive ALL, and dasatinib was found to be superior in inducing less relapses, better event-free survival, overall survival, and less CNS relapses. Therefore, in a pediatric setting, dasatinib was considered standard of care. Unfortunately, in adult, we did not have similar data till recently, where we compared ponatinib to dasatinib. we did perform propensity score matching comparing hyper-CVAD and ponatinib to hyper-CVAD and dasatinib. I share with you the rationale of ponatinib combination. In fact, ponatinib did induce the deeper responses. We improved on a CMR rate, and we improved survival before and after matching, and therefore ponatinib hyper-CVAD has become an option recommended by the NCCN, but this was not a randomized trial. Finally, in March 2019, the FDA approved ponatinib in combination with chemotherapy in a frontline setting in patients with newly diagnosed Philadelphia positive ALL based on an endpoint met, primary endpoint being MRD negative CR at the end of induction. This approval was supported by the finding of the Falcon trial that I will share with you, which was the first head-to-head randomized trial in a frontline Philadelphia positive ALL in adult patients comparing imatinib to ponatinib in combination with chemotherapy. Ponatinib has induced twofold increase of the MRD negative CR, which is the primary endpoint at the end of induction compared to imatinib therapy, and therefore the drug was approved. So here's the design of the trial. It's a randomized trial, 2-to-1, in adult patients with de novo Philadelphia positive ALL, randomized to receive low-dose chemotherapy with ponatinib at 30 milligrams per day. That will be reduced to 15 milligrams per day once a CMR was obtained, or low-dose chemotherapy and imatinib at 600 milligrams per day. Patient will receive induction for 3 months. They will be assessed for the primary endpoint at that time, then consolidation, then we have a maintenance post-consolidation, and then single-agent TKIs. The primary endpoint was MRD negative CR, which is at the end of induction. Key secondary endpoint was event-free survival, and of course survival and safeties. As you can see here, the rate of MRD negative CR, which is composite endpoint, you have to have a CR for 4 weeks, and MRD negativity at 10 to minus 4. This rate was 34.4% with ponatinib compared to 16.7% for imatinib. Now, in real life, in our practice, we do not wait for the CR. If somebody is achieving a CRI based on this protocol was failure. But in our practice, we don't wait for the platelets to normalize. And therefore, if we extrapolate this to our real practice, the rate of MRD negativity will be even higher. Now, that being said, event was defined as no response, loss of hematologic response, death. Molecular responses were not part of the EFS. Patients who did not achieve an MRD negativity at 12 weeks can go on to receive a blinatumomab or even ponatinib if they were on a standard of care arm. That is, per definition, crossover. And despite that, we see a trend for better EFS favoring ponatinib arm. Although the follow-up is still short, we don't have enough events. We need to wait for longer follow-up to confirm the superiority of ponatinib compared to imatinib therapy. However, in our real life, we act on a molecular relapse. If we extrapolate that, means not loss of response, death, but eventually molecular relapse, that will be PFS, and we see a clear benefit in favor of ponatinib. And therefore, ponatinib improved PFS, which is post-hoc analysis, and the primary endpoint, which is MRD negative CR. And what's interesting in this study, there was no increase in the rate of toxicities. We did not see an increase of the vascular event with ponatinib, as was seen in CML experience, due to the fact that, first of all, we have selected patients. Number two is we adjust the dose rapidly, and we know at a lower dose we can skip the problem of vascular events. At the beginning, we were concerned that ponatinib can cause vascular events. Once we look at the toxicities here, what we've seen that the discontinuation rate between ponatinib and imatinib, they're similar. In fact, the adverse events were similar, and mainly what we called arterial-occlusive event were 2% and 1%, no difference between ponatinib and imatinib. So ponatinib is safe TKI to be given, mainly for dose adjustment. And when you look at the discontinuation rate, it's similar between the two arms and the reduction as well. So when it comes to adverse events, there was no difference between the two arms. Venous, 12%, arterial-occlusive event, 2% and 1%. So we're able to improve on efficacy and safety of ponatinib as good as imatinib therapy. So effective and safe drug, better exposure, better long-term outcome. At the ASH meeting, we did subset analysis looking at the impact of this regimen, and we've seen ponatinib benefiting all comers, but in particular, we've seen in older patients where transplant is not an option, a major improvement in PFS compared to for ponatinib compared to patients who receive imatinib therapy.
So, could you just talk a little bit more about the difference between PFS and EFS, and also a little bit about how these trials are done, in terms of what it is
Okay.
that you really want to look at? But can you just
Okay.
elaborate a little bit more about when you
Okay.
do a trial like this in ALL, like how do you look at these endpoints and what are
Okay.
these endpoints?
Okay. Great point. So let me resume here. Here I want to show the details of the Falcon trial, which is a randomized phase 3 trial in adult patients with a newly diagnosed Philadelphia positive ALL who were assigned in 2-to-1 randomization to either ponatinib plus low-dose chemotherapy or imatinib plus low-dose chemotherapy. As an oncologist, what matters to me the most is overall survival. So, what is the primary endpoint of this study? It's very important to highlight the primary endpoint because this is the first time ever in acute leukemia where the FDA agreed to consider MRD negative CR as a primary endpoint. In fact, that was due to a meta-analysis that have shown achievement of MRD negativity correlate with the outcome. Therefore, it's a surrogacy for outcome. So we discussed with the agency at the time to consider MRD negativity CR as the primary endpoint, and the FDA agreed for the first time ever to consider an approval of a drug based on MRD eradication. We know today that we have in ALL we have a drug approved for MRD, but here MRD negative CR was considered as the primary endpoint. Now then the FDA said I want a secondary endpoint, which is long-term outcome. So we discussed with the agency what endpoint it could be acceptable. The key secondary endpoint was event-free survival, and event was defined by no CHR, loss of CHR, or death. So essentially, the minimal disease eradication was not part of the event. And the reason why, because that will be a duplication between the primary endpoint and secondary endpoint. Means in practice, if you have a patient who did lose his or her molecular response, can go on to receive subsequent therapies. This will not be censored as an event for the event-free survival. That means it's a crossover. And when we discussed with the agencies, they said, well, this is the normal practice. And therefore, that should not be an event. And therefore, for event-free survival, loss of molecular response or relapse, molecular relapse was not considered an event. Number one. Number two is survival. And of course, the follow-up is still short for the survival to be different, but we have to wait longer for the follow-up to be seen. Finally, as an investigators, we perform a post-hoc analysis to take into account not only loss of response or death, but loss of molecular response or persistence of minimal disease, and that is PFS. So unlike EFS, PFS is EFS plus loss of molecular response or persistence of molecular disease. And in real life, what matters to us is PFS because that's why we act. And in fact, in this trial, the primary endpoint was met, twofold increase in MRD negativity CR, which is the first time ever shown in ALL, and that translates into better PFS. And despite the crossover, the EFS is trending in favor of ponatinib. Based on these findings, the drug ponatinib was approved for frontline use in Philadelphia positive ALL. And of course, we're awaiting the long-term follow-up, the EFS, to have more events censored, and survival, of course. And all this benefit did come at no price of increase of vascular events, which somebody would worry about with ponatinib because it has been shown in CML to cause vascular events. But here, with the dose adjustment of ponatinib, we're able to control or at least to prevent these vascular events from happening. Of course, longer follow-up is still needed to highlight to see whether this event can happen at the long run or not.
So again, just for oncologists to be able to read this paper, first of all, I don't see overall survival. Was that presented?
Well, we showed yes, it was presented, but there was no the curve were overlapping. The follow-up is still short for any benefit and any difference in
Right. So
survival.
too early. Too early.
Correct.
Okay.
Correct.
Now the next thing is, I think in general when oncologists see PFS, they think about the need to switch therapy to something else. Does that model apply with PFS? Because it sounds like you do switch therapy. I mean, I don't know whether you consider progression or not, but in other words, when you have positive MRD and then you switch therapy, that's the PFS point.
Correct. Correct. This is exactly the PFS point, because in EFS
Okay.
we did not take into account uh, molecular relapse. In real life, we have a drug approved for MRD, and therefore, if you have a disease where you can detect minimal disease, you must change therapy. And we look at the purple curve on imatinib, there was more progression, molecular progression compared to ponatinib, and therefore these patients did receive subsequent therapies.
So, I know I'm kind of trying to simplify something that's very, very complicated, but again, people don't have that much time to really look at it. So, I guess when you look at that top curve, is that kind of your vision of what this therapy, the advantage as opposed, like it looks like there's a greater benefit for PFS than EFS, but I would think clinically it would be the PFS that'd be most relevant. Is that correct?
Correct. Clinically, PFS is what's more relevant, because in EFS, we did not capture molecular relapses, which in real life matters, because if a molecular relapse, you act on it. Actually, if you don't
Right.
act on it, it's a mistake.
Right. Okay. Well, I think that at least kind of brings us into a typical paradigm for oncology. So let's keep going.
Wonderful. And then subsequently, we look into subset analysis, looking at the PFS benefit. And we've seen in the subset analysis, PFS favored ponatinib across all subset. But the advantage mainly was seen, the major advantage was seen in older patients, where the PFS was way bigger for ponatinib, 22 months compared to 8 months for imatinib therapy. And therefore, based on this, ponatinib should be offered as standard of care in Philadelphia positive ALL. No, you ask me, or the question may say, well, these results are good, but they are not as amazing as your excitement, what you show us at the beginning from the MD Anderson. Why is so? Well, I want to walk you through it. In fact, the era of chemotherapy, I think it's past now. We need to look at the modern time, how we can further improve the outcome. And immunotherapy, whether bispecific engagers or ADCs, antibody conjugate, both have shown activity in ALL Philadelphia positive in the relapse setting. Therefore, the next question is, can we take this to the front line and test it in combination with the TKI? And the first study published in New England was from Italy, where they used dasatinib followed by blinatumomab. They give dasatinib for 3 months, and they give a blinatumomab for at least 2 cycles from month 4 and onward. So it's not a concomitant combination, it's sequential. And by doing so, they showed that the rate of complete molecular remission, which is the endpoint, was 41% after 2 cycles. All molecular response were 60%, and cumulatively with time, this rate improved to 87%. We know that early responses matter. With this regimen, half of the patients did receive subsequent transplant. So we did not get rid of transplant. We had relapses being seen. With the long-term follow-up, we have a 4 years, survival is an 80%, which is a benefit or an advantage or an improvement compared to what we had before. Patients who did not do well were patients who did not achieve a CMR early on, and those with the genotype called Icarus deletion plus. I'll come back to that. Essentially, these are patients who have a multiple deletion where we know they do not do well with this combination. Do we go for transplant for them? The answer is yes today, although transplant may not further improve their outcome. This is a sequential combination. At MD Anderson, we elected to use ponatinib plus blinatumomab for the reason I mentioned before, because ponatinib is more potent, it can suppress the emergence of the mutations, but then we combine this in a concomitant fashion from the beginning. We gave ponatinib at 30 milligram per day that was reduced to 15 once the CMR was obtained. We added blinatumomab 5 courses, and then we did maintenance with ponatinib alone 15 milligram per day, and we offered intrathecal chemotherapy up to 15. So it's a change completely of what we had before. There's no chemotherapy whatsoever here. Here the results so far reported at the ASH meeting with an update coming in JCO. 62 patients treated. Unlike the Italian trial, unlike what you expect to do in your real life, only one patient went to transplantation. So we're able to walk away from chemotherapy and transplant. With that, we have a survival at 2 years of a 90%, which is the best seen so far. Responses are universal, and we've shown when we assess for MRD by RT-PCR for BCR-ABL, this rate was 84%, mostly achieved after cycle 1. And we look at the MRD assessment by NGS, looking at the immunoglobulin receptor on a B cell at 1 cell over a million, this rate was a 94%. We've seen 7 relapses, all in P190. Of them, 4 are CNS isolated. And most of these relapses were seen in patients with a white count above 75,000. Therefore, what we have learned here is high white count predicts for CNS relapses. And therefore, while this regimen without chemotherapy is good for all comers, may not be good enough for a patient with a high white count. This patient may still need some systemic chemotherapy. Then we look at responses, dynamic of responses by RT-PCR and NGS. It's important to note here that when you give ponatinib at 30 milligram per day, we did weekly PCR, and we've seen within 2 weeks, most of the patients are achieving the response. That means we're able to reduce the dose of the drug to 15 milligram really early on, and that is very important to avoid any vascular event that can be encountered. So deliver a safe treatment that can prevent or mitigate or avoid vascular events. Then we assess MRD by NGS and after every cycle, and you can see within 3 courses, we have already 90% NGS MRD negativity, which is critical. Why it's important? It's important because if I want to go for transplant, if I have a CMR, transplant will not be needed. It will allow me to decide whether I go for transplant or not. Then we look at the correlation between for MRD assessment by PCR and NGS. What matters is having MRD negativity by NGS. In fact, 5 patients were PCR positive, they were NGS negative, and this patient did not relapse. In contrast, we have 2 patients who were PCR negative, called no disease, but NGS MRD positivity. Of these 2 patients, one patient went on to become MRD negative and when had a relapse. It's very important, therefore, to assess MRD by NGS as well in order to make a decision whether you go for transplant or not. So here I'm showing you the correlation between NGS and PCR for MRD. There are 32% discordance between the 2 techniques. What's better to differentiate the outcome is NGS. You look at the left side of the slide. If you're MRD negative by in blue, you have a 5-year relapse-free survival of 68% compared to 42% if you're NGS positive. Then on the right side, these are all patients who are NGS negative, whether PCR positive or not, it doesn't matter anymore. So rely on NGS, not PCR only. This will bring me to what I will do next and how we can improve the outcome further. This is a data from Italy as well. They're doing ponatinib and blina in frontline situation, and they have a randomized study comparing ponatinib blina to low-dose chemotherapy and imatinib. At the last ASH meeting, they took the experimental arm, ponatinib blina, and they compared it to historical data with dasatinib and blina. They've shown that the combination with ponatinib have a higher rate of MRD negativity at end of induction, going from 29% to 38%. Of course, the follow-up is still short, less relapses on a ponatinib arm. It's very preliminary, but again, highlighting ponatinib being probably superior to the other TKIs available, in particular dasatinib. Yes, sir.
What were the 3 induction deaths?
Not reported. Essentially, toxicities.
I mean, what kind of potentially lethal toxicity do you see with these therapies?
This patient can get a lot of steroid. They can have a COVID infection. It shouldn't be the case, but if you have somebody frail and 75 years old, that could be problematic. But in our experience with the ponatinib upfront, we did not see any toxicities, no deaths, except for thrombocytopenia, one case who had very low platelets, had a bleeding in the brain, and passed away.
Okay, please continue.
Another trial reported this year at ASH, there's another allosteric inhibitor called asciminib, study from Dana-Farber. They combine asciminib and dasatinib and prednisone in a phase 1 study. The recommended phase 2 dose of asciminib was 80 milligram per day. Short follow-up, but I like to highlight the results here. The MR4, which is very important as a because I show you in a Falcon trial, what matters is the MR4. It's only 26%, which I think quite disappointing at this time. That means you need more to this regimen, and one drug to add is a blinatumomab that is being considered right now. With that, the survival at short follow-up is 78% at 2 years. Yes, sir.
I'm just curious, what's the logic of combining asciminib and dasatinib? Are they
Okay.
not similar agents?
No, great question. And I'm glad you interrupted me to highlight that. I mentioned in the beginning of my presentation that the reason why patients failed dasatinib is the emergence of a mutation called T359. Asciminib is an allosteric inhibitor. It does bind to the BCR-ABL oncoprotein in a different way. Therefore, it can overcome the presence of T359 mutation. Therefore, the hypothesis is if we combine these TKIs, we can suppress the resistance emergence of the mutation and improve the outcome. They did this combination, and yet they maybe didn't overcome the mutation of T359, emergence of T359, but it wasn't potent enough. It did not deepen the responses the way we would like them to be deep.
So, but I'm just kind of curious though, why wouldn't they just use asciminib alone?
Because asciminib alone will not improve the MR4. In fact, asciminib alone gets you a 25% MR4, which is not where we want to be.
Interesting. Okay, please
Okay.
continue.
Other strategies in Philadelphia polyLL, we look at olverembatinib. Olverembatinib is a very potent TKI, which is similar to ponatinib. And in this phase 2 study, we had a combination of olverembatinib and venetoclax plus low-dose chemotherapy. At the phase 2 study, 31 patients were enrolled. And here, what we're giving venetoclax plus olverembatinib plus steroid for the cycle 1. And then for cycle 2 and 3, we give ven for 7 days, olverembatinib for 28 days, and prednisone. What we've seen here, the CMR rate was such a combination is 61%, and most of the adverse events were grade 1 and 2. So it's good, but still very early on, we need more data to see whether BCL2 inhibitor is helpful in Philadelphia positive ALL. Yes, sir.
What do we know about venetoclax alone in ALL?
But we don't know anything yet. We hypothesize it may work, but there's no data yet supporting BCL2 inhibitor in ALL.
Okay, please continue.
So what else we can do? What novelties we have in PH for ALL? The CAR T cells. We know that CAR T cells are finding their way in ALL, mainly in relapse setting. This is a small series where patients were treated with dasatinib and CAR T cells upfront. And the idea behind it is if we do CAR T, we can eventually deepen the responses and avoid it for transplant or others. It's a small series again, 18 patients. What we've seen here, we give steroid dasatinib first, and then we give CAR T subsequently. So let me walk you through the data. 18 patients who were induced. CHR was 100%. Again, what mattered is CMR was only 28%. 18 patients received the CAR Ts. CMR rate went up to 72%. And then we had subsequent second CAR T. We have CD19 CAR T first. We went to CMR of 72%. Then we gave CD22 CAR Ts. The CMR went to 77%. With that, the survival is 92%. The point I'm making here is CAR T did not further improve the outcome. We've seen so far giving blinatumomab and ponatinib, we have a higher CMR rate. That's what you can see with the CAR T. Therefore, I don't think CAR T is ready today to the frontline use in Philadelphia positive ALL. Yes, sir.
So I'm not sure I've heard before about trials that plan to give 2 CAR T therapies, which sounds like what was done here.
Correct.
What was the thinking about doing it twice?
So in fact, in this trial, they target CD22 and CD19. So we know if you give CD19, patient may progress and you have an escape. At least by doing dual CAR T, you're targeting CD22 and CD19 and you avoid relapses. So in this trial, in this series, a short series, patients were given prednisone and steroid and dasatinib at the beginning, but then they collected them and they give them CD19 CAR. When they did CD19
Wow.
CAR, the first one, they have 70% response rate. And then we added CD22 CAR T with the hope to further improve the outcome. We couldn't.
Wow. So you hit two targets consecutively. I don't remember hearing
Correct.
about that with CAR T. That's
Correct.
pretty cool. It's
To
too bad
to
it didn't
avoid
work, but it sounds
relapses,
pretty
but it
cool.
didn't. Correct. It didn't work so well. And I think today, if you consider the blina we have and the ponatinib, we're better than the CAR Ts, and therefore I don't think CAR Ts should be used today in the front line. They should be only investigational in a very narrow fashion. So here it will take me where I go for transplant in my practice or CAR T for the sake of CAR Ts. I think based on the data I showed you, ponatinib and blina is really effective. We need to make sure to avoid CML in lymphoblast phase. We induce this patient. We assess for MRD negativity by NGS. If somebody is negative by NGS, then keep your TKI as a maintenance. If somebody is positive by NGS, then do CAR T cells. If become NGS MRD negative, maintain my TKI. If somebody remain MRD positive by NGS despite CAR Ts, then consider allogeneic stem cell transplantation. This is our algorithm today, and more data is coming in that sense.
Could you just elaborate a little bit on CML LBP?
Correct. So today, it's very important to differentiate between de novo ALL or somebody who had a background of CML transformed to lymphoblast phase. It's very important to differentiate that upfront because if you have somebody with CML transforming, transplant is needed. These are patients who are more resistant to treatment than de novo ALL. De novo ALL, you can give them chemotherapy free. CML transforming may need chemotherapy. That's why I said here, unless you have evidence of CML, then do blinatumomab. How do I differentiate these patients? Well, first of all, it's rare to see CML with P190. So if a P190, which is the majority of ALL, Ph positive, then they don't have CML in the background. If they have a P210, a third of them can be transformed. And usually we do FISH analysis on the myeloid cells. So you detect the BCR-ABL cell in the myeloid cells. If you do so, it tells you it's more CML in the background than it is ALL. If it is CML in the background, I think you need chemotherapy and transplant remain an option upfront, unlike de novo ALL. Then, so you have de novo ALL, you induce, you assess for MRD. If you're MRD negative by NGS, this is the best outcome. Keep your TKIs. If you're NGS MRD positive, that means you have a disease present. I'd rather use CAR T in a minimal disease setting. So CAR T will be my way to go. I do CAR T. I monitor post CAR T. If my patient is MRD negative at that time, that is great. It's a winning case. If somebody remain MRD positive, then we should go for transplantation for these patients. So this is how I guide you when to go for transplant or no transplant. So to conclude today, I think we made progress in ALL Philadelphia positive. The first question we have, do we still need a transplant? I think in the majority, transplant is not needed, mainly in patients who responded, who became MRD negative by NGS, again, highlighting the importance of the achievement of MRD negativity by NGS. The genotype of Icarus Plus is bad, but it's really, really rare. The best TKI available, we have a randomized trial that have shown ponatinib to be better than any other TKI. Therefore, in 2024, ponatinib is the best TKI to be given. Do we need intratumoral chemotherapy? The answer is yes. I think 15 is our standard of care today. However, be careful in somebody with a high white count because then they can have a CNS relapses. Can we cure the disease? The answer is yes. We've seen 5 years follow-up where the survival is plateauing with the blina and ponatinib, mainly in patients who don't have CML in the background, who are P190. They do amazingly well with the blina and ponatinib. New drugs to be explored. I'm very excited about subcu blinatumomab. Remember, blinatumomab is a drug to be given infusion 4 weeks every 6 weeks. Today, we're exploring sub-Q formulation. It'll be given 3 times per week, and it's an outpatient. That will be amazing. Asciminib is being explored, and olverembatinib, which is a new drug, is being explored right now in ALL Philadelphia positive. Finally, if I give my treatment TKI, how long do I give my treatment? And exploring what we call treatment-free remission. I think if you're able to have an MRD negativity maintained every 4-6 weeks for the next 3 years or 4 years, then you can cure the disease and we can stop the TKI. With that, I think we made huge progress in ALL. For our reader, for our people, for our colleagues today to look at the data, we made the progress. Started with the purple curve with a pre-TKI survival of 10%. Then adding TKI to chemotherapy, we're at 40-45%. Ponatinib, we went up to 70%. And today, with the chemotherapy-free, our survival at 4 years, 5 years is 90%. So it's a breakthrough from a very poor outcome to a success story with high cure rate of ALL Philadelphia positive. Thank you very much.